Hello, everybody, and welcome back to the podcast. It gives me great pleasure to introduce you to Dr. Jenny Barnes, who is a GP in Warwickshire and a perinatal mental health GP champion. And today we're talking all about perinatal mental health. Welcome, Jenny.
Thanks very much, James, and thanks for having me on the podcast today. It's great to be with you and to talk about what I feel is such an important area of medicine that we can really help our patients with. So a bit of background about me. I am a GP in Warwickshire. I work in Kenilworth. And I've got a particular interest in women's health and particularly perinatal mental health, having had lots of friends, family members, and patients that I've supported through difficult times with their mental health.
It's wonderful, and it's really great to hear that there are champions around for this such an important topic because it's going to be affecting an awful lot of our patients.
And it affects a lot of people. So the project that we've been currently working on is funded by NHS England for East and West Midlands. And we've got GP champions in each ICS putting on education events for the whole of primary care to really increase the education and help support clinicians with seeing these women and families and get the help that these families need.
And that's really great to hear. And what led us to being able to talk today on the podcast was one of those education sessions. And I learned so much, and I really just wanted to share a lot of that learning with the listeners to the podcast. So I think probably the best place for us to start then is, what do we actually mean by perinatal mental health?
So, yeah, brilliant place to start, James. So, perinatal mental health is mental health all the way from conception to a child's first birthday. And it encompasses a lot of different conditions. And there is such an impact on society with families having perinatal mental illness. It's estimated that there's 8 billion a year cost to society through these conditions, and that actually a lot of that is spent on the child. So health consequences of perinatal mental illnesses and then supporting the child with that. And I think partly why it costs society so much is how common it is. And I know when we talked before, it's so common. So it's 1 in 5 women and 1 in 10 men suffer from a perinatal mental illness.
Mm. I mean, it's astoundingly high. I think that when we think about this in practice, we think it's sort of at the fringes. It's an exception rather than the rule. But at 1 in 5, that's a huge number of people affected and a huge number of families affected.
Yeah, absolutely. And the other thing that I think just to get people to think about is really to think about it and look for it. So it is much more common than any other physical health problem in pregnancy. But we spend our time quite rightly picking up those other physical health problems and we monitor them, and people go to their antenatal appointments and have their blood pressure checked. But do we really check how they are with their mental health as well? And so part of this work is just raising the awareness again to clinicians, and also empowering women and families to come forwards if they are struggling to get the help and support that we can give them.
Yeah, I think it's really nice that we highlight that it's women and families, and I didn't pick up on it just a second ago, but astoundingly, 1 in 10 men that's suffering from issues in perinatal mental health as well. It's astoundingly high in probably a very overlooked subsection.
I think you're absolutely right, James. It absolutely is. We think about the women and the children, but men are going through this too. But how many times do we ask a man about this, or are they even coming to see us about it? So it's really important to remember the whole family.
Yeah. I think that's really, really powerful and something I took away from the first time I listened to you, and certainly now something to highlight to our listeners. So we're obviously talking about a really big problem here, a really broad problem too. So I think it's really important to think about overall what we mean by perinatal mental health, because I understand it affects a lot of different aspects. We're not just talking depression here, are we?
Yeah, absolutely right, James. So there is a broad number of conditions that come under the umbrella of perinatal mental health. And they're quite a wide variety. It's not just the depression, or as clinicians, we worry about missing the psychosis. There are adjustment disorders, perinatal PTSD, OCD, and anxiety all come within that term.
Mm. And you mentioned that we worry about missing psychosis. I understand that we're in the region of about 0.2% of the total amount is psychosis, of course, very severe, but we've then got a very large number of people, if we're talking about 1 in 5 or 1 in 10 respectively, dealing with a lot of other issues. Now, what was the most common presentation of perinatal mental health?
So probably the most common is actually the adjustment disorders and the bonding disorders. Um, is the most common in number, and that can affect families and women significantly. So this comes into a lot of the background of the of mental health, in that we put pressure on women to fall in love with their babies straight away. But actually, the evidence is that only 40% of women fall in love with their baby straight away. So actually, more people don't than do, which isn't talked about.
Yeah, difficult to talk about.
Yeah, it is, because society doesn't at times let us talk about it, and social media and what we should be feeling. So I think there comes into, there's a lot of reasons why a lot of this mental health problems happen.
Yeah, and I can quite imagine. And I think trying to pick it up from our consultations and having those conversations with patients is so important. And we're going to talk about that in quite a lot more detail at the second part of this podcast. But just having it in our mind of the potential impact and potential prevalence, I think is so important. So adjustment disorder, you say, is the most common type, and an attachment. What do we actually mean by that? What is an adjustment disorder in this context?
So there is a DSM-5 definition of adjustment disorder, but in a nutshell, it's really the development of emotional behavioral symptoms in response to an identified stressor, which then has significant impairment on function. So really, we're talking about normally that being either delivery or pregnancy, and then that having a significant impairment on that woman or that family's ability to function.
Mm. And suppose that also then goes into the postnatal period as well, with the impact on life and the changing needs and responsibilities for a family.
Yeah, absolutely. So it goes all the way up to the child's first birthday. So you've got a massive developmental period and change in families, change in relationships at home, and what life means to everyone individually within that unit.
Yeah, a big upheaval in any respect, but evidently it affects some people to a greater degree, and having sort of fallout into other aspects of their week.
Yeah, absolutely. And sometimes we can pick up those people and those families. So there are some common risk factors for developing perinatal mental health problems. And there are some that are probably a bit more unusual, that I wasn't aware of when I particularly went down this training route. So we talk about the toxic trio. So being particularly aware of these situations, people who've had previous mental illness, substance misuse, and domestic violence. And that's a very high risk scenario. And also other common risk factors that you might be aware of. So poor social support, difficulties with relationships. But there are some more unusual ones when I was going through this training. So having an unplanned pregnancy is actually a risk factor for this.
Yeah, that's surprising, I suppose, and also not surprising in some aspects. Going to be a big change, isn't it?
It's a massive change if you weren't planning it. But actually, what then surprised me even more, and I guess is that 45% of pregnancies are unplanned or not quite intended, but
Yeah.
in that situation.
Yeah.
Which is why thinking about contraception is so important with aspects of particularly postnatal care with women. It's actually more common to have mental health problems in a second or third pregnancies.
Right.
So I think sometimes we worry about the first time mums more, and you've done it once, you know what you're doing next time. But there can be lots of other factors. So you've now got another child to look after, different things going on. So it's really taking into account the whole social circumstances.
And I suppose, again, it comes down to the communication part of this, and the fact that we naturally think, "Oh, you've been down this before, our second one, I'm sure it's much easier," but actually you've got to juggle lots more things, and the impact on your life might be increased. Um, so I what I challenge myself there is the way that we respond to people making that sort of statement, or actually a family.
Yeah, absolutely. And thinking about the communication and the questions we ask, and not putting our expectations of what that situation might be onto those women. Not breastfeeding is also a risk factor,
Okay.
for mental health problems. Whether that comes, it's probably multifactorial, whether that's society pressures and what women feel like sort of failing if they can't breastfeed, sort of hormonal influence on that. But that surprised me a little bit as well.
Yeah, I suppose it's part of the sort of the societal view of the perinatal time, and I suppose what it means to have a baby and what should be expected of it, and the taboos around what we are comfortable talking about and what we aren't comfortable talking about, and what we should expect or might expect to expect when you're expecting, um, rather than the reality of it is very different, and it's not what you see on social media. It's not what people talk about necessarily, but the reality of which can be really challenging for people.
Yeah, and I think that's why we really need to support women. So it's talking to them and realizing that, people don't put posts on social media when they're having such a difficult time, but they're putting pictures of their baby smiling and everything being happy. So there's a big campaign about look behind the smile. So a woman might come in with her baby, you know, or looks absolutely fine, smiling away, but ask a few more questions and look behind that smile and really find out what's going on. And that's how we can help support these families. And it's really shocking actually that we are only picking up about half of perinatal mental illnesses. So we
Only
talk about it
half.
as being the hidden half.
Yeah.
And if you think about that being, a cancer, or another sort of physical health condition, and we were missing half of cases, I think there'd be more of an outcry in society. But we still have some of the stigma of this being a mental health problem. So we're actually only picking up half of women and families. And then if we pick them up, we're only actually managing to treat half of them effectively. So that kind of really means we're only getting the care we would like to give these families in a quarter of the time.
Astoundingly low. So it's sort of compounded by not picking it up, which is us not asking the questions, and patients perhaps not recognizing that they need some additional support. And then when we have identified it, not treating it as well as we could. Amazing to get the head around. Astounding.
Yeah, and this is why we're wanting to put this education out there, and it's brilliant. We can get with you getting this podcast done as well.
So yeah, well, I mean, I'm really glad to hear you. I mean, I think everybody's going to learn so much from this discussion. So we've obviously mentioned that we're missing half picking it up. In your opinion, why aren't we picking it up? What is in the way of us going? Well, actually, if it's 1 in 5, that should be something we see so frequently that we should be just. Well, okay, I know what I'm looking for here.
So I think there's multiple factors on different levels. Absolutely. Um, and you can think about it for the different areas of the system. So why are women not coming forward with this and families? So think about the patient. A lot of women still feel that if they say that they're having a problem, then they're worried that we'll take their babies away from them. So there's still that stigma and fear and worry, and that they shouldn't be feeling like this, that this makes them a bad mum, that they should be doing better, that this is the most natural thing in the world to have a baby, and that saying I'm struggling with it means that there's something wrong with them. So patients aren't coming to see us to start with. And then when they do get to see us, it's really difficult as a clinician to be able to spend the time that you need sometimes with this. So I think sometimes the system doesn't help. So, how long have we got with each patient to really ask those questions? It's much easier to ask a question and to invite an answer of I'm fine rather than really finding out what's going on, and going back to what I said before about looking behind that smile. So what is really happening for that patient? So I think it's taking the opportunities when we get them to really find out what's going on for our patients. It might be that we are seeing the baby all the time. And that's the beauty of being in general practice and having access to the whole family, hopefully, is that you can be nosy and you can have a look and see what's going on. So, mum might be bringing in the baby with really things that you think are really small and sort of trivial. Actually, it's her mental health that's the problem rather than the baby having a physical problem. So, it's thinking about asking those questions. And partly why we've been doing the education as well is to be able to give clinicians the resources to be able to then signpost women, because clinicians were telling us that they didn't want to ask those questions because they then didn't know what to do when patients made a disclosure to them. So there are so many resources that you can use for your patients. And I think we're going to come on to them in a second podcast, James, because there's so much to talk about.
Absolutely, it's a huge topic, and something I think that we don't explore nearly enough in general practice training, and I don't think we talk about it enough within our teams. So I'm really looking forward to coming on to what we can actually do to support our patients in the second podcast. Um, we've been talking about communication a lot here, and I think the language is really vital to get right. Have you got any tips for us of how we can approach that?
Yes, absolutely. And I think it's really important. I think the first thing to say is just go back to your communication skills that you had in medical school or through your training, and think about those open questions that aren't leading, that don't carry any judgment with them. And I'll give you a few sort of examples. So, quite often, women will probably come in and you think, oh, it's a bit of the baby blues. And you're trying to be a really good doctor and reassure them and saying, oh, this is really normal. But just think about that language. And I just encourage you to think about not using the word normal, because to that woman, it isn't normal. She is feeling awful. And by using the word normal, it's minimizing her symptoms to her. Think about using the word common instead. So, this is really common. Thank you for coming to talk to me, and we can help you, and we will help you together. And just that would be a change in phrase that I'd really encourage people to think about. Along the sort of lines of normal as well, just think about how you ask about a woman's birth. Um, and so, again, open questions. Tell me about your birth. Rather than having a look at the notes and trying to speed it up a bit, or I can see you've had a cesarean section. And also just think about the language again around vaginal delivery and not thinking about saying a normal. And we don't help ourselves. It's normal vaginal delivery, is what we're taught. But there's a lot of PTSD that comes after deliveries. And a lot of that is from women not having had a vaginal delivery, of having had to have a cesarean, and they feel that they've sort of failed, that this isn't what nature intended. So if you can just think about it being a vaginal delivery or a cesarean section, again, you don't carry any judgment with the language that you're using.
I think that's very helpful to hear, to change the conversation and to change the language that we use to help people express themselves in the way that they want to, in the way that is real and meaningful to them. I think we really easy to put words in people's mouths, and the idea of the normal vaginal delivery, which is kind of how in the terms that we talk about this in obstetrics, but actually it's incredibly meaningful time for a patient. And as you mentioned earlier, often the pivotal point where they might suffer from PTSD afterwards or anxiety, and things like that. So thank you for sharing that with us. You also mentioned when we were sort of discussing this before about sort of specific phrases of sort of detecting low mood or other mental health aspects. Can you explain that to us?
Yeah, so I think there's a few questions that I really like to ask mums. One of them's around sleep. So the question I really like is, please don't ask a new mum if she's getting any sleep. There is a rubbish question to be asked, and I still remember it with my three. Um, but instead, just change the phrasing of it. So, can you sleep when your baby is asleep? And that just changes the emphasis on it, because if a woman can't switch off when their baby is asleep, then it really means that that brain and that chemical sort of activity is on overdrive. And that should be a really big red flag for anyone saying that to you, to think, I really need to help this woman. So that's one really big tip to really pick up. And that can pick up, it could be anxiety, it could be depression. It may also not last for very long and settle down, but it's a really useful question to ask. And within thinking about the questions I like to ask, a really open one. How are you finding being a mum? Really open. It's not carrying any judgment with it. Whereas I think sometimes we're tempted to say, oh, congratulations, it must be amazing, your baby looks beautiful. And of course, be encouraging and enthusiastic, but just give them the space and the openness to really say how they're feeling.
Yeah, because behind that smile might be a mum that is really struggling or a family that is really struggling.
Yeah, absolutely.
Well, thank you so much, Jenny. I think we've covered an awful lot today, in terms of like putting this really into context and figuring out what it is that we don't know about perinatal mental health. And I think that what's really spoken to me today is about the power of language in the consultation, as well as just thinking much more broadly that perinatal mental health is not just depression. It's not, it's not anxiety in particular. It can affect anybody in the family and can be very wide ranging. So that's what I've really taken away from today.
Yeah, absolutely. And it's also, it's not that complicated. I just encourage everyone to think about that. The questions that we've been talking about, you can all ask them. It's just having the time and thinking about it.
Wonderful. And sage words to end on. Now, I'm really happy to say that we've got a second podcast coming up where we're going to be exploring some of the aspects of the 6 week check. We're going to look at a bit more about social media, a little bit more about the impact on the family. We're going to look a lot more about OCD and intrusive thoughts, which are what really surprised me when we learned about it before. So I'm really, really looking forward to that. But for today, thank you so much, Jenny, for your time. I've learned a lot. I'm sure everybody listening at home has too. And I really look forward to our next podcast.
Brilliant. Thanks, James. Thanks for having me. And I look forward to talking again soon.
Wonderful. Thanks.